Good afternoon and welcome to the fourth session of our five-part series, Urology Speaks. My name is Alan Parton and I serve as the director of the Brady Urological Institute and urologist in chief for Johns Hopkins Medicine. In a few moments, I'll introduce our speaker for today's webinar, Dr. Andrew Cohen, who will lead our talk titled Cancer Survivorship, Opportunities of Reconstructive Urology. I hope that each of you is well and settled into warmer weather and increased opportunities for outdoor activities after a particularly long winter. I'm so pleased that you're joining us today for Dr. Andrew Cohen's talk about the intersection of improved cancer survivorship and the particular paths for improvement through reconstructive urology. The Brady is fortunate to have a number of experts within this area of urology here on our staff. Their work does so much to transform day-to-day health and overall well-being for our patients. It is within this space that our patients move beyond surviving into thriving. Whether you have personal benefit from the care of our reconstructive urology team, or you're interested in learning more about this work, I know that today's presentation will be a fascinating look at this specialty of our field that isn't always front and center, despite the tremendous impact of the work. Those of you who have joined us for some of our past webinars have heard me share the story of the Brady's beginning. Philanthropy established our institute in 1915 when Diamond Jim Brady, a patient of Dr. Hugh Hampton Young, made a generous gift to build and launch the Brady Urological Institute in Dr. Young's honor. The unlikely partnership of a railroad executive famous for extravagant tastes and a world-renowned physician established the foundation for all that the Brady Urological Institute would come to be and all that it continues to be for our patients today. Many of you on this webinar have provided support for our mission, and I want to thank you sincerely for your role in continuing to build on this legacy. Philanthropy is a part of all that we do here at the Brady, and I know that future support will be of particular importance to the continued growth of our urologic reconstructive program as we seek to expand access to life-changing improvements and procedures. Today's webinar is being recorded and will be made available if you would like to share the recording with your friends or family who might have an interest in this topic. At the conclusion of Dr. Cohen's presentation, we'll take your questions and ask you to please use the Q&A button at the bottom of your Zoom screen to ask a question. We will try our best to answer as many as we can. And now I proudly introduce Dr. Andrew Cohen. Dr. Cohen recently joined our team as an assistant professor of urology at Johns Hopkins, and he serves as the director of trauma and reconstructive surgery at the Brady Urological Institute at Bayview Medical Center. Already in his short tenure with us, Dr. Cohen has started to make an incredible mark and has earned the respect of his colleagues, mentees, and patients. In fact, Dr. Cohen recently was nominated for an Excellence in Mentoring Award by Johns Hopkins Medicine, which is a tremendous testament to his commitment to academic medicine. Dr. Cohen has a robust clinical practice focusing on complex genitourinary reconstruction and other benign urologic conditions, and he has extensive experience in robotic surgery and focuses on issues pertinent to cancer survivorship in men. Dr. Cohen received dual Bachelor of Science degrees as summa cum laude from University of Florida in both chemistry and chemical engineering, followed by an MD from the University of Chicago. And Dr. Cohen completed a fellowship in genitourinary reconstruction and trauma at the University of California, San Francisco. Andy, I now turn over the mic to you.
Thank you. It's an honor and a privilege to be able to present about a topic that I am very passionate about today. And I hope that I can really sort of explain what this whole idea of cancer survivorship is and leave you with some new ideas about how this can really improve patients' health for dealing with cancer. And so, to jump right in, what is cancer survivorship? What is it that I'm talking about? And remarkably, there has been vast improvements in how we are able to get patients beyond their cancer treatment. And so if you look in the 1970s, very few patients survived for many years after a cancer diagnosis. And to this day, now there are millions, this coming year, estimated 18 million Americans that are surviving past their cancer diagnosis. And the majority of those people are living many, many years beyond the cancer diagnosis. And that is a fantastic achievement. And it is in part because of the tremendous work that has been done here at Johns Hopkins and at other leading centers across the nation. And much of that advancement has only been possible through philanthropy and the hard work of basic scientists and clinicians. But, cancer and surviving cancer can really transform a person. There's often physical and psychosocial transformation among the survivors. And so, looking here, firstly, if you think about the medical effects, it's sort of in this outer circle of this diagram. So cancer survivors may have to face sort of daily pain or new fatigue. They may have issues sleeping. They may live in a constant fear that their cancer may return, which can lead to anxiety and depression. They may have issues with their nerves because of chemotherapy, having trouble using their hands or always feeling that tingling sensation when your arm falls asleep. They may live with that on a daily basis. They can have hormonal abnormalities, dealing with hot flashes or early menopause in the case of women. There can be impacts on their bone health, on their strength. They can have cognitive impairment. They can have bowel, bladder, or sexual dysfunction. And all these things can interact to cause differences in their how they sort of go throughout life. There can be issues with spiritual awareness. There can be issues with social isolation. They may lose their job and therefore be facing severe economic hardships. They may have a role disruption. They used to be the sole breadwinner for their family, and now they no longer are fulfilling that role that gave them a lot of meaning. And so there's a lot of ongoing research and a lot of things that we can do to help support the cancer survivor and help them live life to the fullest now that they have a reasonable expectation of living 10, 15 years after their cancer diagnosis and treatment. And particularly for me, I can make the most impact when I help patients who are suffering with sexual dysfunction or bowel or bladder dysfunction that unfortunately is often accompanying cancer treatment. But I'm not alone in this endeavor, and it is really a true honor to present today. But I only represent one of many who are trailblazers in this field, who work here at Johns Hopkins within urology and outside of urology, who have contributed to the science of cancer survivorship over the years. And our current team really offers years of experience and is really been attributed with cutting edge discovery in this area. And so, Dr. Burnett, Dr. Moswin, world-renowned, Dr. Bivalacqua, who has a special interest in sexual health, Dr. Clifton, who I believe is giving the next Urology Speaks seminar, whose focuses on female urologic issues, myself and my other partner, Dr. Wright. And we work in a multidisciplinary team. Kristen Farling is an amazing nurse practitioner whose specific charge is cancer survivorship and issues related to cancer survivorship. And we often work hand in hand with physical therapists, such as Mary Austin and Kenzie Worthington, to help patients regain those pivotal functions that really, really help them as they face the world after the cancer has been cured. And one could argue that the whole idea of cancer survivorship actually was born here at the Brady, when Dr. Patrick Walsh in 1981 developed the nerve-sparing radical prostatectomy to treat prostate cancer. And the reason why I say this is because then after that discovery, for the first time, people with prostate cancer could be treated and come to our institution with a reasonable expectation of having their cancer cured, as well as getting out of that cure good urinary control and good sexual function, two things that are very important if you're a cancer survivor of prostate cancer. And we've made other discoveries throughout the last few decades. Dr. Olof is currently trying to figure out ways to reconstruct the bladder after prostate cancer surgery to give men immediate control over their urination. Dr. Moswin has done fantastic basic science foundational work to understand how the bladder works in the cases of outflow obstruction, which often can happen because of cancer. Dr. Burnett really made the landmark discovery of nitrous oxide, which is really the main neurotransmitter that controls male sexual function. And from this discovery directly came the creation of those medicines that many people have heard of, Viagra, Cialis, that are really the mainstay of treatment for male cancer survivors with sexual health issues. And so I could go on and on and on with a list of past discoveries and what we've done here to help cancer survivors within urology and beyond. But I really want to spend the majority of the talk looking a little bit towards the future and looking at what we're planning on doing in the years to come to really transform this space and really help cancer survivors moving forward. And so to that end, I'm going to focus on a few topics. First, I'm going to talk about urinary incontinence, or the leakage of urine. So how big of a problem is this? Well, let's look at it from an economic standpoint. This is the amount of money that's spent in North America on things to control urinary leakage: diapers, pads, pull-up type products in adults. And so this last year, $15 billion were spent on these products. That is a big problem. And so why is this such a big problem for cancer survivors? Well, it has a lot to do with anatomy. So this is a diagram that shows you the male urinary anatomy, very simplified. In the male anatomy, the urinary control mechanism really depends on two sphincters. There's an internal sphincter between the bladder and the prostate. That's here. And there's an external sphincter that's a little bit further away from the bladder, but nonetheless is close to the prostate. So obviously in urology, we're very focused on the prostate, and any sort of treatment for prostate cancer is going to potentially put these sphincters at risk. Similarly, in female patients, the uterus, very close to the sphincter. The other things that aren't on this diagram are the rectum, which is right behind all this, and the bowel contents. And the bony anatomy is all right scrunched together in a really small space. So any sort of cancer treatment for those conditions can lead to urinary dysfunction. In fact, for women, for instance, that are getting some sort of surgery in the gynecological organs for cancer, 80% of those women end up with some urinary dysfunction, including leakage. An abdominal perineal resection has to do with rectal cancer, colorectal cancer. Again, almost half of those patients have urinary dysfunction after that cancer treatment. Sacral resection for the bone that's right sort of where you sit, on your buttocks, 93% of those patients develop urinary problems. Luckily, because of the work of Dr. Walsh and others here, prostate cancer surgery actually has a very low risk of long-term urinary issues. But prostate cancer still remains very common, and therefore prostate cancer treatment remains very common. So 5% of a large number is unfortunately still a large number. So it affects a large number of patients. Now, this sort of problem of urinary leakage is usually undertreated, and there's a number of reasons why. Cancer survivors usually expect the medical team to bring up this problem. Hey, how are you urinating? It may be culturally taboo for patients to bring this up to a doctor. Many cancer survivors think to themselves, I leak urine, but this isn't important. I'm fighting cancer. that's really the most important thing. I don't need to worry about this. I don't want to bring this up to my doctor. Unfortunately, we know, at least in prostate cancer, that these types of issues that affect quality of life can have a significant negative psychological effect and actually can lead to clinical depression if they go unserviced and unrecognized and untreated. So how do we currently treat urinary leakage? Sometimes we use pelvic floor physical therapy to rehabilitate. There are some non-FDA approved off-label medicines that have a very mild effect that can improve leakage. But by and large, currently we use surgery to help this problem. And the current gold standard surgery for urinary leakage is the implantation of this silicone device called the artificial urinary sphincter. And this device hasn't really changed in a number of decades. It has three parts. It has a pressure regulating balloon that looks like a balloon. It has a pump that you press to activate it. And it has a cuff that goes around the urethra. And basically, this is how this thing works. It's all under the skin. When the man wants to urinate, he grasps the pump and he firmly presses it. This causes liquid to circulate within the system, and it gets transmitted, the pressure gets transmitted to the cuff, which then opens and allows the man to urinate. After about 60 seconds, the cuff refills with liquid, blocking the urination from happening thenceforth, therefore preventing leakage. And so this is very effective and can dramatically improve leakage in men who have leakage after various types of cancer treatments. And so, I think that one very important thing that we know about putting these in men is that experience matters. If you look across the country, on average, a urologist puts in one of these every 6 months. And in this particular study, they identified that the top performers did 8 of these procedures in a 6-month period. Here at Johns Hopkins, we are in the top 1% of volume of doing these procedures. We have a lot of experience. In pre-COVID times, when we had no restrictions, I would argue that we probably did 8 of these in a week. So what does that allow us to do? That allows us to be at the forefront of discovery, of understanding how do these work and how can we improve them? How can we advance the field and make our patients' lives better? To that end, we very recently put together a database, IRB approved, retrospective series of over 400 of our recently implanted patients. And we maintain this database with a team approach of medical students and research associates and our residents and care teams. And really, this is possible because of the gracious participation of our patients and the fact that they trust us to perform this type of surgery. And it really allows us to make further discoveries. And so just this year, we've submitted 3 projects to our international meeting of the American Urological Association from this data. And this work is going to allow us to optimize our current generation of technology and provide the best outcomes for our patients. And so, the details are unimportant, but we've made a lot of novel findings. So this is an example of one of these projects that we've recently completed. And there's a lot of controversy about whether these sphincter devices work as well in people that have a history of radiation. And we found that actually the radiation doesn't matter as much as people have thought. And the real detriment to the long-term success of this device is mechanical failure. It's a device, it's a physical thing, and it simply can break. So, my partner, Dr. Wright, recently asked a very vital question. Well, if it breaks so often, which part is the part that breaks? And we found that over a third of the time, it's that pressure regulating balloon. And so we've created a strategy here to replace that balloon and do a more minimally invasive salvage procedure when it's necessary to get patients their urinary control faster and better when and if the thing does break. We've learned a lot of other things. We've learned that the device doesn't work as well as we would like. It requires a good percentage of the time, it requires that you need a revision because something breaks. The device can fatigue. We've learned that you can salvage this device just by replacing that reservoir. But essentially, the real thing that we've learned is that there's room for improvement. And so let's look to the future. So if you tell me that the vast majority of the time, the pressure regulating balloon is the thing that breaks, well, let's get rid of that thing. So the middle diagram is a suggested device. It's not available in the United States. It's called a Zephyr. And this device eliminates that part that seems to be the most likely to break. But I would say, let's go even further. I think simpler is better. The only thing that you really need in order to block the flow of urine is something around the urethra. And so really the gold standard should be developing something that has a cuff without any button, without any cuff, without anything that can break. And so because of philanthropy, I've been able to collaborate with the Hopkins Extreme Materials Institute. And what we're trying to do is we're trying to adopt this shape-defying metal that can be programmed to move in a magnetic field or with temperature changes. And we're trying to adopt this technology and put this around the urethra so that there are much less parts, there's no fluid to leak, and that men who are facing leakage after cancer treatment can expect good continence with a much simpler approach. And we're hopeful that this is going to really revolutionize how we treat this in years to come. The other thing is, if you think about it, we control a lot of things remotely. You go into your car, it's connected to your phone. You can get a refrigerator that emails you when you're running out of milk. And so, when we talk about how to control these devices, there is a real push to implement some modern technology that would really allow people, even with dexterity issues, people with neuropathy issues, allow them to control the device easily. So I would argue that we can implement novel controls to this type of device so that you can control your urination as easily as pressing a button on your phone. So I think that the future is bright in this area. I think that we can't forget that as we improve our cancer treatments, the risk of having urinary issues should go down naturally with time. I think that we have to continue to optimize our current generation of surgical techniques by learning about what's working and what's not working. But I really think that the key is looking at innovations and designs and controls and longevity and effectiveness for these types of things. And I'm very hopeful that we're going to have all the tools at our disposal here to do that with the help of philanthropy. So next, I want to talk about a very exciting topic, which is tissue engineering. And unfortunately, there are many unintended consequences of cancer treatment. And in particular, radiation. Radiation can cure your cancer. But the way it works, it has unintended consequences of fibrosis and inflammation that can really wreak havoc on nearby structures, healthy structures that you don't really want to harm. And in urology, we're really working with very delicate plumbing. And so this is sort of a diagram of sort of a urinary tube. And normally it has a nice open channel for the urine to flow. But sometimes with cancer treatment, what can happen is that tube can fill with scar because of bad blood flow or because of some other reasons. And so you get a small hole instead of a nice large capacity for urine to flow. And this can happen anywhere along the urinary tract. So this is just a reminder of your anatomy here with a special kind of 3D scan that we sometimes do with patients. The red here is the kidney that actually makes the urine. The yellow is the delicate tube that drains the kidney called the ureter. That drains down to the big yellow blob sitting in the bony pelvis. That's the bladder. And then the bladder, of course, drains through the urethra, which in men is a little bit longer, but still serves the same purpose. So if we focus for a moment on the urethra, oftentimes because of radiation, we find scar tissue forms there, or what we usually call a stricture. And so sort of our current low-tech way of tissue engineering is to use tissue from somewhere else in the body to reconstruct that urethra. And what we often use is mouth tissue, or so-called buccal graft. We use this because it's used to being wet. We use this because your mouth heals well. You know that if you ever accidentally bite the inside of your cheek. And so we often are able to take a little bit of a inner cheek tissue and move it over to reconstruct the urethra. and then we close off the cheek. Now, this often has some challenges associated with it. The mouth has limited surface area. It's opening up a new incision site that can get scarred down. It can get infected. There's a lot of postoperative pain. If anyone's ever been to the dentist, you know it's not so fun to deal with mouth-related things. And also, it isn't urethra. It's mouth tissue. So it doesn't always work. You can have leak where you put it in the urethra. You can have restrictures there. So it's not perfect. There's a similar problem in bladder cancer. Sometimes in bladder cancer, the bladder has to be removed, which leads to the obvious question, well, what are you going to replace it with? And so usually what we do is we use bowel, but that leads to leaks and fistulas and electrolyte imbalances and low appetite and a lengthy recovery before the bowels come back to normal. So what would be better? Well, what about tissue engineering? Can we grow a new urethra or new bladder? Can we take someone's own cells and use special 3D bioprinting to create a scaffold so that we can grow a new tissue that would be just as good as the one that you were born with, but cancer-free? And at Hopkins, we have tried this. Dr. Bivawakwa has been instrumental in these earth-shattering attempts to create a new type of urinary drainage system. And he's created the so-called Neourinary Conduit, using someone's own fat cells to grow a replacement for the bladder. And we've noticed in the initial human trials that there's been very promising urinary-like regeneration of cells, but there's challenges ahead. We've had some obstructions, we've seen some strictures. So there's still a lot of work, a lot of opportunity to get this better and get this working so that we can actually use this in patients. In my part, I have a special interest in these urethral strictures, and I'm collaborating with Dr. Singh, who is an excellent basic scientist with an engineering background and a special interest in bioengineering. And we're unique at the Brady in that we have these types of experts within our own department. And he and I are sort of asking the question of what is going on the cellular level in these urethral scars, many of which are due to cancer treatments. And so we're actually going to look at what cells are active and in what proportion and where within the scar. And we have about 1.7 million cells that we're ready to run through our initial analysis. And this is all work that's only been possible because of generous philanthropy. And the long-term vision of this work is to see, can we identify a chemical or a cofactor or a growth factor that could tell the cells that are causing the problem to just chill out and go away and actually allow the urethra to become more normal without doing any surgery at all? That would be an amazing promise that I think that because of the wonderful relationships and collaborations and knowledge and know-how here at the Brady is something that would be possible for us to learn here. The last major topic that I want to talk about today is robotic surgery. And so, robotic surgery is something that is happening more and more, but it's very rare to find reconstructive urology being done robotically. And that's usually because our surgeries are complex. Patients have had cancer treatment. They've had radiation. They've had cancer surgery. It's not the first time someone has been working in their abdomen. And so when you have to do a big incision, that leads to a long hospital stay, prolonged absence from work, difficulty dealing with the pain of a big incision, a lot of blood loss, and it's just a challenge for people to get over that type of big surgery. And so classically, the robotic surgery was not possible for these big surgeries in cancer survivors when they were necessary. But I'm here to tell you that that is changing. And so this is just an example for those of you that have never seen it. This is a robotic surgery platform. This is called a single port robot. And you can see here that there's telescoping arms. There is a camera that can be controlled. You'll see here in a moment, this is the joystick through which a surgeon controls all these movements. This robot does not move independently. And using instruments like these, fine instruments with fine motor control, I believe it is possible to do complex reconstructive surgery in cancer survivors when it's necessary using a minimally invasive approach. And so this has been recognized in cancer care for many years. This is some work that I published many years ago. Prostate cancer surgery back in 2013, 80% of the time that was done with robotic surgery. And there's similar trends for all the other malignancies that are out there. Overall, robotic surgery probably now accounts for about a quarter of all surgeries. So robotic surgery is more and more common, but I often hear from my patients, I was told I can't have robotic surgery because I've had prior surgery. I'm here to tell you that not in all cases is that true. Prior surgery is not a contraindication for robotic surgery. This is a picture of my standard patient. They got multiple scars, there's multiple wounds. And, originally, a few years ago, you'd say, well, we're just going to have to do a big open incision to get you through this surgery. But now we do this robotically. I do this robotically. And patients get out of the hospital the next day. It's amazing. So, an example of that and how we're combining ideas of tissue engineering and robotics is that sometimes the ureter, that delicate tube, can get clogged. And we're combining the idea of a buccal graft and these robotic platforms to correct issues and blockages in anywhere in the urinary tract, but in particular in those delicate ureters, and getting people home the next day. So what are the advantages of robotic reconstruction? You get magnified vision. You get this very careful and precise tissue handling. There's absolutely no tremor that a surgeon may have naturally or unnaturally. It's eliminated. Again, I already mentioned the quicker recovery. Certainly it's a small incision, so there's less pain and a quicker return to work. And then there's something to be said, and we're doing ongoing research on this, about ergonomics and surgeon comfort. You do robotic surgery sitting down. You're very relaxed. There's hardly any fatigue. I think having your surgeon working at the top of their mental prowess really can reduce complications and make them able to work for longer. It's another amazing attribute of the robot is we're able to use this special firefly imaging. This is a methodology where we put a special medicine into the blood that only binds with blood cells. And then we use a laser light to basically look for this chemical, and it fluoresces green. And I'm actually, in the next few slides, I'm going to show you an example of that in one of my patients. So if you don't like looking at blood or you don't want to see intraoperative photos, I'd suggest you just listen to my voice, close your eyes for a few minutes. Okay, I'll tell you when it's safe to look again. So we're going to start looking at something that one may consider gory in 3, 2, 1. So this is an intraoperative photo of a woman who I'm trying to fix her ureter. And I'll put a little diagram up on top. The aorta, the major blood vessel in the body, is down below. Ureter in the middle, gonadal vein up top. And here you're going to see the video. Okay, again, ureter's in the middle, gonadal vein up top, aorta on the bottom. We've given this special ICG chemical. You're going to start to see the blood flow in the aorta turn bright green. That's what we expect. It's full of blood. We also see the gonadal vein light up. What you don't see is very much blood flow in the ureter. There's a single blood vessel there. So this allows me to see what you can't see with the naked eye, which is the ureter's not getting any blood flow. I have to fix that. And so this is something only possible with robotic instrumentation. All right, people that are squeamish can open their eyes. The other thing that we can do with the robot that was really hard to deal with before is something called a bladder neck obstruction after cancer treatment. A lot of these we can deal with simple dilations, but if that fails, it's a major problem. So our protocol here is to do an aggressive dilation and put in a novel chemical to help prevent scar from building up. But if that fails, we can do a robotic reconstruction of the bladder neck, which has not been possible, a decade ago. So at this point, I'd like to summarize. And I've borrowed these ideas from Dr. Gearhart, who actually presented the last Urology Speaks, because I think by and large, they're all amazing, and I really respect him. But, my conclusion is cancer care does not end with cancer cure. And we have to support our patients and help them maintain a good quality of life. I think for the types of surgeries that these cancer survivors need, it's important that patients go to a high volume center so that they get the wealth of experience of a good team to give them good outcomes. I think it's really important that we support a center where discovery is important and underway. And I can't stress enough, for these types of problems, the importance of philanthropy to discovery. I have a paper that I'm about to publish. We looked at grants within urology, and there's been an increase in grant submission in urology, but a decrease in funding over the last 10 years. And if you look at a topic such as urinary leakage or incontinence, only 7% of federal grants were awarded for that topic over 10 years, the vast minority. So we really depend on philanthropy in order to make advances in this space. And so we very much appreciate it. And with your help, I think we can continue to make great strides for cancer survivorship here at the Brady. Thank you. I'd love to start the question and answer session.
Thank you so much, Dr. Cohen. That was fantastic. And I know we have a lot of comments coming in from people who just wanted to say thank you and that they so enjoyed the session. So I'm going to start with just the first question being, at what point in your urology practice did you become interested in cancer survivorship, and how did that occur?
Yeah, I actually I didn't realize it, but as a medical student, I became interested in cancer survivorship. One of my mentors at the University of Chicago, the great Gregory Bales, his practice focused on cancer survivorship. And when I was rotating as a third-year medical student, I ended up on his service. And so he is the one who actually inspired me to go into urology. And I was always sort of gravitated towards his practice and his clinical experiences. And so I think it was through that introduction that I started to go down the path, and I never really looked back. I think there's nothing really like being able to help someone with these types of intimate issues. You really get to know patients. You really get to know everything about them and their families. You gain a lot of trust, and you really can make a huge, huge impact. And the answer isn't always surgery. Sometimes there's a simple solution for these problems that can make an immense improvement in their quality of life. And it's just that, they haven't had someone who's been able to focus on that with them before meeting myself or one of the many excellent physicians here at Hopkins who has these sort of ideas of quality of life at the forefront of how we tackle problems.
That's great. Thank you so much. We've got some more specific questions coming in. So I'm going to attempt to do these some justice in my reading. So the first question is, has anyone tried electrical stimulation of the perineal muscles as a means to stimulate the external sphincter?
Yeah, so there is a growing push to sort of jumpstart the nervous system to help with urinary function. So not necessarily the pelvic muscles, but the bladder itself. And there is something called PTNS, peripheral tibial nerve stimulation, where you actually, through a needle in the lower leg, you can send pulsations through the nervous system to help reprogram the bladder. And that's usually done for overactive bladder. There's a few other things that's indicated for, but it can help reprogram the neural circuitry, if you will, to the bladder. The other way to do that is with an implant or a sacral neuromodulator that actually gets implanted into the back and has little electrodes that go directly into around the nerves in the back and help reprogram the bladder. In terms of the sphincter itself, certainly with physical therapy, sometimes we use vibration therapy or TENS packs that can help with the muscle rehabilitation there. But directly applying electrodes to regenerate the sphincter, to my knowledge, is not something that we do in current practice.
Wonderful. Thank you. Next question. What is the threshold of incontinence that warrants surgery?
This is a fantastic question. And it's a quality of life problem. So everyone is different. I have patients that leak constantly. They require full-on adult diapers, and they're not bothered by it. It doesn't bother them. And so for that patient, we're not going to do surgery. they're adjusted, they're having a good quality of life, it's not a problem for them. I have other patients that use 2 pads a day, and it drives them absolutely up the wall, and they don't tolerate it, and they have a terrible quality of life. And so it's a personal decision. As long as kidney function is okay, as long as the bladder is emptying, there's no major detriment to your health. There certainly is maybe a risk of skin issues or urinary tract infections, but by and large, many of these problems relate to quality of life. And so it really has to do with each individual patient, what they're trying to achieve, what their personal values are, and how we can best help them. Not everyone decides to get a surgery, but for those that do, we try to do an exemplary job.
Wonderful. We have a question coming in. What engineering resources are you using to bring the best technologies to the leakage resolution for post-prostate men, including engineering expertise outside of the medical industry?
Yeah, that's a great question. So, part of that particular project that we're working on with the Extremes Material Institute, it brings in a lot of outside resources through our venture office. And so I've been instructed not to divulge too much information about that particular project, but I can say that we have some industry partners that we may be seeking to collaborate with as we learn more about how that technology can be harnessed. And so certainly we're open to working with content experts outside of our institution, if and when that is appropriate.
I've seen a fascinating project that Dr. Wright has been doing with some of the bioengineering students. And they get together and he tells them our clinical need, and they put their young engineering minds together to try to come up with solutions. And I think that's been an excellent collaboration. I know you've been working with them as well, Andy.
Regarding your work in companies, asking how often does the equipment need to be upgraded, and do you partner with the manufacturers to kind of provide that real-time feedback based on your patient experience?
Yeah, so the robotic surgery space is evolving. It's very interesting right now because until recently there was really a single company that was monopolizing the robotic landscape, but there are sort of competitors that are on the horizon. And I think it's an evolving field in terms of how things are moving forward. So more to come in the future.
I was on Twitter this morning and saw somebody ask if anyone was still using the SI robot, and that was the first one that I was able to use back in 2004. And most of the answers were coming back, haven't turned it on in 10 years. So. We've come a long way and the robots do change, but thank God not that often.
Dr. Parton, there's a question for you asking, how does someone make their way to a specialist like Dr. Cohen? Is it typically a referral from an existing urologist? How does that typically happen?
He might be able to answer that better than me, but I refer all of my patients that need his care to him. He is our, expert in that area, but he gets referrals from outside, from primary care physicians, from other urologists at other institutions. We've been trying to make it very obvious that, we're into major reconstructive efforts here at the Brady.
Yeah, any patient can sort of, I think, call our general scheduling line and request to see one of our physicians here. If they've never been a patient before, they just have to register. But it should be relatively easy if anyone is sort of seeking a personal consultation.
Thank you so much for that. Another attendee is mentioning that you briefly mentioned regenerative medicine. Is there a day when important urological organs can be grown in the lab or 3D printed?
Yeah, I think that I certainly hope so. I think that it's places like the Brady where we're going to make those fundamental discoveries to, if it is possible, to do it in a place like this. I think that we have some challenges ahead of us to make it work. But I think that as a theoretical idea, it certainly is fantastic. And I'm optimistic that with our giant leaps in printing technology and everything we're learning, that it will one day be possible. Certainly not something that's going to happen in the next 5 years. Probably not something that's going to happen in the next 10 years. But I just started my career. So I got a lot of energy, and let's see if we can make it happen.
That's a wonderful answer. And kind of building off of that, what development in the reconstructive urology space are you most excited by? What's most exciting to you of the moment or of the near future?
Well, someone asked about sort of robotic technology. I'm really excited about robotic miniaturization. I think that it is in the medium term that we're going to have robots that are so small that I'm going to be able to operate inside the urethra without making a cut on the skin, and still be able to do everything that I need to do. And in particular for a urethral scar, that's really going to be transformative. And so I'm very excited about that. I think that that's something that may happen sooner than we actually think.
Mary and I are probably seeing the same questions you are. And one of them is asking if during a prostatectomy, reconnecting the ureters is considered difficult. We try not to have to do that. That's part of the connection to the bladder that stays intact during the operation. Reconstructing the urethra, not the ureter, to the urethra, that is very difficult. And that's one of the things that I think robotic surgery has been a game changer for, at least for me in doing the operation, because we can sew it like a baseball, if you know how the threads are around a baseball, and make it watertight. We can check it. We know it's watertight before we leave the operating room. So that's a very important part of the operation that, if done incorrectly, leads to having to see Andy later on.
I think that's a great segue into this question as well, which is a reconstructive urologist always consulted after the fact, or are there pre-surgery evaluations?
For people that are high risk for some of the side effects of cancer treatments, we often can do a pre-treatment evaluation where we kind of talk about what may happen and what can be done in those situations, if that makes people feel comfortable. A lot of times people that are pre-treatment, they're really focused on curing the cancer. And so sometimes it's more of a distraction to get into the hypotheticals, but we're here to help people make a decision about their cancer treatment and help make a decision about their quality of life issues. And so if it's helpful for us to meet with them before treatment, we're happy to do so. But the vast majority of time, I usually see patients after they've developed some sort of cancer, related quality of life issue.
In the case of the bladder cancer patients, it's very important for people to see the reconstructive surgeon before the operation, because I think you probably have 5 or 6 different options, and sometimes that decision is made during the surgery to remove the bladder. So it's good to hear what the possibilities are beforehand.
And I think we're very blessed here at the Brady that our cancer surgeons that remove the bladder also so happen to be experts in all of the reconstructive techniques. So it becomes a sort of a one-stop shop for patients who unfortunately have bladder cancer and are dealing with those questions.
So related to that, are there preventative steps that can be taken to ease some of the symptoms and conditions that you described?
I'm sorry, can you repeat the question or provide a little specifics?
I think just in general, I think the question is related to kind of preoperative care. Is there anything in particular that, can be done to limit the types of conditions that you go to see, or are these kind of, is it a case by case kind of complications?
So yeah, I mean, the treatment of cancer is complicated, and sometimes it's hard to predict what the potential consequences can be. It doesn't affect everybody, and so and every cancer is approached somewhat differently. In general, I think it's always a good idea if you're planning a big surgery to do a little prehab. Make sure your nutrition is good. If you're overweight, lose a little weight. If you're underweight, gain a little weight. Do a lot of walking before you're getting cancer treatment or you're getting chemo. But I think if there's a specific problem, that's when I can sort of step in.
That's wonderful. Dr. Parton, Dr. Cohen was mentioning the importance of building towards a high volume center. Could you kind of expand on the significance of that and the possibilities kind of very specific to the Brady in that space?
I think the statistics that Andy started with showing that the typical urologist who's well-trained and running an excellent practice in the community may only do 1 or 2 of these operations a year. And we have found, and all of the literature supports the fact that if you do high volume, repetitive operations, analyze your results, keep metrics, and then study what went well and what went wrong, you tend to end up being better. And our goal in trying to build the reconstructive urology program for both men, women, and for cancer has been to make that possible. And Andy's just one example of the people in our group that are high volume surgeons, not taking prostates out, but in working on problems like this. And that's been my vision since I became the director, is to not just have the best prostate cancer center in the country, but also build up these other areas as well.
Thank you so much. Dr. Cohen, you mentioned the psychosocial aspects of cancer survivorship. So what do you recommend to your patients in need of that specialty expertise?
Yeah, that's an excellent question. I think that I work in partnership with a lot of different collaborators on clinical problems. And so, we have psychiatrists, psychologists, sometimes endocrinologists for particular hormonal imbalances that we work with regularly. Kristen Farling, she is amazing, working with our prostate cancer survivors. And, not only does she work on their medical problems, but she has the time and takes a lot of effort to get to know couples if there's sexual issues and really support them fully. I can't understate that sometimes the issues the cancer survivors face are multifactorial. And they may come to me with a urinary problem, but I discover that really there's a clinical depression that needs to be addressed that's more pressing. And so we often have to look at the whole patient. I'm a doctor first, and then I'm a urologist.
I think one of the new programs that we've started, and I know Andy's been influential in working with, is working with the rehab people to try to get patients to them before they undergo their operations and to see them after. You do not undergo orthopedic surgery of any type without having a rehab appointment when you leave the hospital. And our goal is to try to make that possible for urology patients as well. So that's brand new for us, and we're learning our way through it. But thankfully, Andy's been working with the group there at Hopkins to set that up.
That's great. And speaking about your current practice, we just have a question coming through asking, how has COVID-19 impacted your practice? And have you had to adapt protocols and procedures?
Yeah, early on, like many medical centers, we had a pretty drastic pause in in-person visits and some elective surgeries. But we're pretty much back at full court press at this point, seeing patients in clinic and working through our patients that want surgery. There's still, the procedures that I do are still elective procedures. I'm not the one, as Dr. Parton said, I'm not the one curing the cancer. So that does still have to take precedence if there's any limits on hospital beds or supplies. But by and large, we're still moving forward at this point. And we're taking a lot, we've learned a lot through this COVID experience. We have a huge number of precautions in place. And pretty much the vast majority of the medical staff and everyone working in the hospital has been offered a vaccine. So we feel very safe at work. We have standards and precautions about wearing masks and face shields. Patients before procedures are, for their own safety and the safety of our staff, are checked for COVID to make sure that there's not going to be any spread in the hospital. And so, I feel very safe at work. I feel very safe to continue to help patients. And I think moving forward, we're looking forward to continue to expand and get back to pre-COVID volume levels.
Andy, how does a suprapubic tube fit into consideration for treatment of incontinence?
Yeah. So a suprapubic tube, sometimes is helpful for incontinence. This is a tube that goes below the belly button and goes directly into the bladder. And so it's sort of a way to divert the urine away from the normal way that it comes out. The issue with the suprapubic tube as a solution is that your native urethra is still open and gravity may work against you. So, the suprapubic tube is always going to be higher than the normal exit. You think about it like a house, the suprapubic tube is on the second floor. And so, if you still got liquid that's on the first floor, it may still leak out your front door. And so it's usually not our primary treatment option. Sometimes in rare cases, we close the urethra surgically and leave a suprapubic tube. That's a rare way of dealing with things. Usually we try to do something to help support your own sphincter, either using this artificial sphincter device that I mentioned or sling procedure to help, just limit that leakage.
Thank you. It looks like we have time for just one more question, with thanks to you both for your time today. You mentioned that only 7% of NIH grants for urology in the past 10 years were focused on incontinence. What do you think can make a difference in reestablishing this as an area of priority?
Well, I think that, I showed you that slide about the finances of incontinence products. I think that there's a lot of baby boomers that are coming of age, and these types of problems and quality of life problems are going to take up an immense amount of people's and health insurance companies' budgets. And so by simple economics, I think this is going to become more of a priority for research and efforts from our government to support ways to solve this problem, just in a simple effort to save our healthcare system a little bit of money. And I also think that people will vote with their problems. If more people have these problems, then there's going to be more attention to it. There's going to be more demand that we have better solutions. And so my hope is all that drives the field forward and provides us with, a little more resources.
Well, once again, thank you, Dr. Cohen, for joining us this afternoon, for your presentation, and for answering so many excellent questions for us. The seminar was absolutely fabulous. We also want to thank you people that chimed in today. We hit over 90 at one point. I've been following the participants at the bottom. We want to thank you for your continued support of the Brady and for Johns Hopkins Medicine. And I want to remind you that our last session of these series is going to be on June 10th. And at that time, Dr. Marissa Clifton, the director of our Women's Health Center at the Brady, is going to discuss her innovations in care on the treatment of female urinary incontinence and related issues affecting women. So thanks again to everybody and best wishes to you all.